All right. Good morning, everyone. First of all, thank you. For those of you who want to obtain a CME, you could obtain a free CME for this session. It is 1 hour. And if you've already registered for this the CME session, please text 251 to that number, 844-912-1333. And it is very easy to obtain the CME nowadays. So I would like to share this case, and I wanted your input because I've told this patient of mine that I would discuss at this meeting and get the insight from all the experts here. And we did actually discuss this case in our PAP conference last week. And at the outset, I want to thank everyone and also thank my panel members, experts, Selvi, Sylvia, Ravi, Sriram, Roy, Joseph, and everyone else who has joined today. And we also mark this as our completion of the first year of doing these Zoom sessions. And we have done about 46 sessions so far. Thanks to you all.
Thank you.
And I want to thank the support of my institution and Dr. John Stoline, Mr. Charles Butt, and Angela Deal for their help and support. So this is a story of a woman who is about 70 years of age, and she is about 5 hours from where we practice. She is in the middle of Texas. She has she was taken care at MD Anderson for stage 3 inflammatory left breast cancer, and she has done well. And she's been doing well, except for the past history of ulcerative colitis that was diagnosed at age 15. And she reports that she was initially treated with sulfasalazine, but been in remission for the last 20 years and has been off medication. She also has a history of acid reflux, and she had 1 bout of C. diff colitis in 2017. She has hypothyroidism and a mild iron deficiency anemia, for which she takes over-the-counter iron supplements. So otherwise, she has been in good health. Interestingly, she had a positive Cologuard in December and a little bit of a low hemoglobin, for which she underwent colonoscopy. And colonoscopy revealed basically normal-looking colon, no colitis, a 4 millimeter polyp in the hepatic flexure, and then another one in the same area, and then normal colon in the left colon. Biopsy showed basically normal colon, no colitis, nothing of concern. The endoscopist reports congestion and nodularity in the distal rectum. He felt it was a laterally spreading adenomatous lesion. That's basically copied his report and pasted here. So, and the pathology from the biopsy showed, right colon, left colon, nothing. Basically, no histological abnormality except for hyperplastic polyps. And then the rectum showed fragments of sessile serrated adenoma. She's not on any antithrombotics, and she has no implants. So as you can see here, this is the endoscopy report, the color photos. You can see the cecum, terminal ileum, ileocecal valve on the upper panel, And then the hyperplastic polyp in the hepatic flexure in the second panel. And in the lower panel, right lower down, you see that congested nodular area in the rectum. So why don't I stop here and let you comment on what do you think, and I'll share with you what I thought. How about you comment on, maybe start with either Sylvia, Roy, or anyone who wants to take a chance and share your thoughts.
Did you say that the patient has ulcerative colitis?
Mm-hmm.
So this colorful
at age 15, and she was treated for some time with sulfasalazine, and she's now 70 plus, and for 20 years she has been off treatment, no colitis, nothing.
Yeah, but this colorful pictures are the wrong color. This is done without following the guidelines. So they had performed NBI, which is not recommended, which is has been shown to show of no benefit in the detection of lesions in patients with ulcerative colitis. It should have been done with the blue color.
Okay.
So it's colorful, but it's the wrong color.
All right.
I have a comment also, Raju.
Uh-huh.
So, the fact that she had a Cologuard done, the Cologuard is really for average risk colon cancer screening. And this patient, like Roy was saying, has chronic ulcerative colitis. And she should have been undergoing close endoscopic surveillance with 4-quadrant biopsies every 10 centimeters using chromoendoscopy, which is what Roy is saying.
Right.
For surveillance of dysplasia. So I think the Cologuard was inappropriately used in this circumstance. And I think the way the procedure was done, in addition to the lack of chromoendoscopy, maybe they took more biopsies and it's just not on that slide, but that's an inadequate number of biopsies for surveillance of dysplasia.
May I have a quick comment as well? Regarding the photo documentation, just in general, recent data have shown that a large proportion of the colonoscopy do not contain adequate photo documentation, complete photo documentation, and actually in less than half of the patients who developed post-colonoscopy cancer, the photo documentation at the last examination was incomplete, making it difficult to make any judgments. And what I would like to highlight in this case series, so the first 3 pictures in the top are cecum, the appendiceal orifice, terminal ileum, and ileocecal valve, which is good. So we always have to provide a high quality photo documentation of at least 2 of these 3 landmarks, anatomic landmarks, then photo documentation of each anatomic segment. And last but not least, in this case, very important to me, I'd like to see a retroflexion, because the only picture to document the rectal lesion is the last picture, if I'm correct, which shows congestion and nodularity, but it's only one picture, again NBI and not chromoendoscopy dye-based. But even in this case, I would like to see the retroflexion to better estimate this, the size of the lesion, try to delineate the borders. So do we have the retroflexion pictures?
This is what we have.
This is all what we have. Okay.
Yeah.
So Raju, despite the lack of completeness of the exam that she needed, the last picture actually tells you what the problem she has. So there is this area that looks more light green. It's a white area. That area has not been properly described in the literature. Rafi just texted this is like a case that he had seen, but this area endoscopically that I know of also has not been described in our literature. This area will be biopsied, and some pathologists will call it as hyperplastic. Some others may call it SSA, but this is a new entity that is increasingly being described. It's going to be called sessile, serrated epithelial changes, SEC. It is thought to be changes that is associated with an increased risk for colon cancer. So if you biopsy this, you're going to find it. The issue that you're asking is that what do we do with it? When you do the colonoscopy yourself, you will probably find big patches of areas like this in the colon, and you're going to like scratch your head and saying like, how do I remove all of these different patches? Because they are huge. And it's like never, it's an endless findings of these patches. And I don't know what the true answer is, because all of these things is still being studied.
Thank you. I think it's a good input. Okay, let's go to the case. And what I'm going to do is, you guys bear with me. So what I've done is, I'll tell you the story as it happened. I went into the rectum, and then I decided that let me examine the entire colon. And when I do my IBD surveillance exams, I do, I take care of only a few patients. I don't have a big practice for this. And what I do is I go to the cecum, come back from the cecum to the rectum, examining with white light, and then go back and then do the chromoendoscopy. That's what I do. So in this case, what you will see is that my first run from the cecum to the rectum, and then we went ahead and did the chromoendoscopy. I'm not going to show you the chromoendoscopy of from the cecum to the rectum. I'll just show the rectum because of time constraints. And then we can discuss what we found. And the reason I left this video unedited is for you to comment. I want this to be an opportunity for all the experts to comment on what you're seeing, what you would do differently, what I should have done differently. So this is a video that is totally unedited. You have to bear with me for the next 13, 14 minutes because that's what it took. And you can see the time on the left side. And I didn't cut even a single bit of video frame from this one. So as we go, each one of you take a turn and tell me, comment on, what's going on, what you would see, what you would expect to see, and what would you do different. And this is more for the learning for the trainees as well. How do you actually screen the colon? So why don't we start with maybe Selvi or Sri Ram, and then go around.
I'll let Sri Ram go, Roger, because he had his hand raised earlier.
All right. Good morning, everyone. Thank you. In the original, this is an excellent demonstration of how a withdrawal to be done in spiral fashion, covering all the areas. So there's nothing much to comment on Dr. Raju's withdrawal of colonoscopy. Only thing I would have done differently is chromoscopy that Roy already mentioned before. So no waiting on that again. I do have a question about what is the validity of patient given report of ulcerative colitis at the age of 15 and never needing any treatment and not needing any not taking any medications. And when she was diagnosed at 15, she's 70 now. That is, we are depending on a diagnosis of 55 years ago, and who knows what is the quality of the care at that time. We are not sure, but and we don't have any histology evidence of colitis in her. So I would just rather look at it, look at her as a fresh case, and look at the lesions that needed attention, and that is that. And fortunately, the changes Dr. Satakno described are more confined to rectum than probably not other areas. So that lesion, once we take care, should be helpful. But now we are stuck at one particular area demonstrating epithelial changes there. Hopefully.
So Sriram, I'm glad that you brought it up, because that's one thing that we should ask. We should make sure that the trainees in the learning should always question the value of that history, because the percentage of IBD patients who have one serious episode and go into remission is very small. And in her case, the story was she was diagnosed at that time. And the second thing is she was treated with sulfasalazine for several years, and then off treatment for last several years. You know, it's a you do raise an important point. Question is now, you know, it's the 70s, is almost 55 years back. You know, how was the diagnosis made?
I would still agree with Roy's comment about the chromoscopy. Now going back from whatever the kind of nature of the lesion that we are seeing that was reported in rectum makes me suspicious. Could there be other lesions of similar nature in the rest of the colon that are difficult for me to examine with white light? So it makes very good sense, and also giving respect to what patient said. If she said colitis, at least we need to give some credence to it. So we do a chromoscopy in that sense also.
Yeah, you're right. So for for those of you were wondering what we found when we did the chroma endoscopy after doing the white light exam, we found two more hyperplastic polyps on dye spray chroma endoscopy. I did not find any more adenomas with the dye spray. And what I've done is, at that time, I basically used Roy's scenic protocol, 2 vials of indigo carmine in the water pump. I think it's 500 cc, 250 cc or something like that. So Roy, Ravi.
Yes. Yes, sir.
Okay, want to hear your comments. Just share something, because it's good for people to listen so that they can get a feel for what is happening and also learn. And the only reason I thought that, okay, let's keep it unedited so that people know when you do an unedited video, they can see what we see and what we don't see, you know.
So yeah, I thought at the end of this video, I would like to share a similar case which I saw, so that they can have a contrast of or can compare and contrast how the lesion looks like. So I agree with whatever previous comments that were made. Essentially, whenever we encounter patients with long-standing IBD, and whenever they come for screening or any kind of colonoscopies, the two things which you want to know is how active is the disease. If the disease is active, then uh, it becomes impossible for us to do chromandoscopy. The second thing is in setting when the disease is in remission and the patient is coming for surveillance, then chromandoscopy is the way to go. And it in fact helps us to identify lesions And as in we see in scenic guidelines, we are always looking for lesions that appear red, that appear slightly different from the surrounding mucosa. We're going to look for lesion that has a border, and we're going to assess if the lesion has ulcers, those that are slightly elevated. And particularly in IBD, what's interesting, or what's somewhat contrasting to other kind of surveillance colonoscopy, is the lesions that we are going to look sometimes can be very flat, like truly flat lesions. So we need to look for these subtle changes when we particularly perform surveillance colonoscopy in IBD patients.
Okay, let's go share our thoughts on what we are seeing, because there may be audience that they're straining their eyes looking for a flat lesion. But I think we have done a brief evaluation of what people are thinking. So I'm going to just share as what we are looking at it, and tell you why what we are thinking. So here there are bubbles. He's washing it, and we are trying to see if the area looks to have the lines. So let's see, is there any lines in that area? So that area has many lines. So we immediately see that there is no lesion. That area has, all of that area has no lesion. There are lines there. There's no redness. That's good. See all of those lines. We are done with that area. We are done. Go to the other side of the wall. All of this area have no changes in color. The innominate grooves are there. We are done with that area. Turn around. Look at the other side. The colon has a shape. It's not very tubular. So that helps because then we know that she doesn't really need a random biopsy. There are like studies to show that when the colon is tubular in UC patients, you need to do random biopsies in addition to chromo. No redness. All of these areas have lines. Done. So my brain is not really looking for a lesion that's protruding. That's easy to be found. It's not even looking for lesions that are flat or depressed. I'm just looking at these different lines. And these lines are so beautiful. They're all there. There is no area that has no lines. So I know that there is no flat lesions in anywhere here. The reason why the lines are more important for me at this time is because the fascicles, the vasculature pattern is not seen, which is sometimes or commonly seen when we do a colonoscopy. So all of these areas have no fascicles that are seen. So I'm just looking at the presence of the lines. So all of the innominate grooves are there. He needs to see to the left. Look at that area. Are there any innominate grooves in the areas visualized? Yes, there are. Turn around, make a circular movement. It's a good exam, but then my eyes are very strained because these lines are not very sharp. So the easiest is to just highlight these lines using the chromoendoscopy. And then you are much more effective. There's something there up there. Let's go back, look up, wash that area, make sure that it has the same pattern. There's nothing now after washing. So that's good. All of these areas have lines. The innominated groups are intact. Done. Come back, please. look around.
I'm Roy's fellow now.
I know it's, but my eyes are straining because there's no blueness. So in scenic, we do not recommend to come back 2 passes, but this is actually good because now you can have a comparison between white light and chromo. One of the disadvantages of doing chromo in one pass is that you don't have documentation of the lesion in white light typically. So here there is no vascular pattern, but there are the innominate grooves. So I'm good. She also has no diverticular disease, which is commonly seen, I think, in patients with UC. The reason I don't know. All of these areas have lines. I'm done. I'm done. Come back. What is that at 1 o'clock? Wash. Okay, good. Has lines. I'm done. So I've been kind of interrogating the mind, trying to understand what the trainees are looking at when they do examination of the colon, and they're so busy looking for protruding and non-protruding lesions. And I say, wow, you're going to have like a very tired mind after the procedure, because I don't really look for any of those lesions. I just look for these lines and vascular patterns, and also color changes. So in this area, now there's something that's slightly different. Oh, I'm at the rectum now, at the anus. Let's see, somebody had said something, there is a lesion here.
That's it.
That's it. Okay, so now let's see the chromo of the sigmoid and rectum maybe. Okay. No.
The chromo, we couldn't see anything.
Okay.
Right, I'll put it this way. When we did the chromo, I couldn't see anything. And then I was about to say, hey, I don't see what the guy saw. And then I called in Selvi. I said, Selvi, I want you to look at it together. And Selvi said, I can't see anything with the chromo either. Why don't you do an NBI? So that was a great suggestion by Selvi. And this is what we saw together.
So this is chromo NBI after washing
Chromo.
off the chromo.
Yeah.
So there's a patch at 9 to 11 o'clock. There's a small patch. There's also a patch from 5 o'clock to about 3 o'clock.
So basically, the patch was, can you see my arrow?
Yeah.
So the patch is, this is the close to the dentate line at the top and below. And the patch goes from here, 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 here. It's almost 80% plus.
Yeah, from the limited cases I've seen and what I've looked at the literature, you will need to find a pathologist who can diagnose SEC. And that is not a commonly described disease yet.
If you look at it here, right. I just cut off that video because I thought that you guys will be tired looking at that 14-minute video on another NBI. So when we did the NBI, I couldn't see. I actually, my nurse, my technician, everybody was looking at the screen and we couldn't see. And then I was about to give up. And then I said, hey, Selvi, come on in. I want you to look at it with me to just make sure that I'm not missing something. And Selvi, why don't you make a comment? So,
Sure, Raju.
yeah.
Yeah, so just as you said, I mean, when we were looking at it under chroma, it was very difficult to distinguish where the lesion was. But whenever I see a polyp under white light, I always turn on NBI just to try to make a little bit of a, amateur, nice classification attempt. And so when we put the NBI on, and it's a good thing that we did, because it looks like the picture that they sent you from the outside colonoscopy report, that's really where they saw it also, wasn't it? That last picture on the report that you showed us.
Yeah.
And then it was pretty obvious.
Right. I really appreciated you making that comment. I probably would have come out, to be honest with you.
Of course, Raju.
Yeah, you did it.
So here is the problem that I think you guys might encounter, because the eyes can only see what the brain sees. And the brain here will need to be a pathologist that can diagnose SEC. There are only limited centers in the world that have described SEC. I think in the US, the group that I know of is at Hopkins. Looking at this, I think this is an SEC. There is no area that appeared to be dysplastic, but I still would want to spray a deeper, darker dye.
Okay.
And then I would see, you see the border of this area is going from about 545 going up there, and then go around, go there. Yes. I think you should let Ravi share his case.
Okay,
because then you have an idea what this is.
All right, I'll show you this one.
So here you can see that the congested, dilated glands, those are the big O signs. They are seen in serrated lesions.
Right.
So I know what this is.
Right. So what I did was, if in case we need to do an ESD, I thought that, okay, I'll take a biopsy from the edge. And then I was looking for, you see this, these glands, right? You can see the gland here.
Yeah, this so serrated
Right.
glands.
Right. So I basically put the first biopsy in a separate jar. And I took a biopsy from this area and put it in a separate jar. And I mentioned that this is the anterior wall of the rectum, and about 8 centimeters from the bottom, so that I know exactly where I took the biopsy. And I didn't want to take a bunch of biopsies because I was focusing, and then I took a picture of that area, and then I took a biopsy. So for the sake of trainees, I want to share with you, how do you figure out in the rectum, anterior wall, posterior wall. So if you're not sure, put some water or whatever into the rectum and see where it settles down, right? The patient is in the left lateral position. This is the dependent portion. And in front of it is anterior wall, behind it is posterior wall, and that is the right, and this is the left. So that's how you do that. So just keep it in mind. If you want to describe where a particular lesion is, may not be important in this one, but if you see a carcinoid tumor and you want to say, where is that carcinoid? Then you want to say anterior wall, posterior wall, left wall, right wall, or whatever. And the distance from your anal verge. So what do you expect the pathology to be?
It may be, I cannot say anything. It's recorded. I don't think it will be SEC. But endoscopically, it is SEC. So the serrations in SEC look different. The glands that are the glands of SEC that are dilated don't touch the musculus mucosa. So they are, so here, I don't know what this is. Is there any dysplastic changes on the
No.
area about 2 to 3 o'clock? Did they call that?
No.
No, those are
dysplastic
no.
change.
Okay.
There is one crypt at 12 o'clock, a bit to the central part, which may have pseudostratification of the nuclei, but I'm
Yeah.
not sure. We need a pathology.
But next to it, Sylvia, is about 11:30 or so. Maybe there's like serrated changes there.
They have,
Uh,
yeah, clear
they
serrated.
do, and then it's very interesting. They don't touch the musculus mucosa as much. They are like hanging in the middle of it.
Right. So
I'm not really comfortable with pathology of SEC.
So we reviewed this, and I'll let Selvi comment on that.
oh, Raju, I didn't realize I was going to be commenting on that. Okay.
Okay.
So that's okay. I can say I always have
You
something
are a
to say.
better pathologist than me. So.
Well, anyway, that's that's not saying much, I don't think. So just like the comments that Roy and Sylvia made, you see these dilated, serrated glands at 10 o'clock, for example. They're kind of clear to see. And the fact is those don't touch the muscularis mucosa, which is the pink line there, where all the other glands are lining up. So my understanding is that if you have those glands and they don't touch the muscularis mucosa, they're not boot shaped, then that by definition is a hyperplastic polyp, or at least hyperplastic changes. And if they touch the muscularis mucosa, then that's more suggestive of a sessile serrated lesion. And this is kind of very focally present. You can see it's just really in the left hemisphere of the slide. The crypts on the right side look pretty good. They're all kind of lining up. They're not dilated. Everything else looks good.
I think this is the trap that I have been worried that you guys will go into. Somebody call it hyperplastic, and the changes in SEC are very similar to hyperplastic. The problem is that the hyperplastic does not confer a higher risk of cancer,
Right.
and SEC does.
Right.
And if you make this wrong diagnosis, you're going to potentially put her into danger because you have only sampled a very small area of the SEC.
Right. Roy, I think I for one need to do more reading about serrated epithelial changes. Just thinking back, it doesn't sound like a completely foreign term to me. So I feel like I've seen my pathology reports come back with those changes. This lesion was only sampled. So we know that there's much more and potentially more advanced pathology or more distinctive changes of SEC or an SSL that may be present if other areas of the lesion are biopsied. But let me ask you a question.
Let me make a comment here. I think what happened was, in terms of the question that was going on in my mind was, hey, does this lesion that is 90% or 80% of the rectum to be removed with ESD, right? That's a big question. It's not a 2 centimeter lesion. It is a 5 to 7 centimeter near circumferential lesion that needs to be removed, if it needs to be removed. So as part of that, when we biopsied, one of the things that I said to myself is scan that area and find that area where the crypts are not round, but have a little more different than round. Round is going to be, or may not come back as more advanced. So I picked up that particular area, which is limited to just less than 1 millimeter that you saw in this video. You can actually see this video, and you will see that actually, as you can see the video here. So here, it doesn't look much different, but as you go past this area to the other side, then you see the crypt was a little bit abnormal. And there is also a little bit of hyperemia in that area, as you can see, as you go there and find that glands here. There are just a few areas that, around this area. So that's what it is. So the thing is, why don't we leave it here? And I want to ask the group, Roy, if you see this lady in your clinic, would you tell her to go near circumferential ESD now at 72 years of age, when you don't have any colitis and anything else in the rest of the colon?
The first thing I would do is that I would confirm the pathology findings by sending it to IBD center with a pathologist who have described SEC. And at present, I know of only one in the US. Around the world, there are other centers.
So the guys who described, so this was a pathology slide that was seen by a bunch of pathologists at MD Anderson who are basically looking for cancer and very experienced pathologists. And having said that, the SEC, the serrated epithelial change description, is it widely accepted with no room for inter-observer variation, or whatever it is?
Well, if
we know the natural history of that lesion for sure.
As I said, it's a newly described lesion. It seems to be real. Now people, I'm glad you described this, because now, it's like being described more and more. But if the pathologists are not specializing in this, they wouldn't be looking at this.
My question, Roy, sorry. I'm also not so familiar with the sessile serrated epithelial changes. What is the certainty of evidence about these lesions? Is it coming from
well, when people haven't really described it, how can we be talking about it?
So there are no studies, or what is the level of evidence?
It's still being studied. It's like I think at this point it's case series.
Case series. Okay.
This is just in the past maybe 6-7 years. This is like a topic that Robert Rouse and I were working on before he passed away.
Okay.
You said it increased the risk for colon cancer though, Roy, right?
Correct. This has been associated with colon cancer in UC patients.
In UC, okay.
Can I make a point? In 1965, when I was a senior medical student, I was running a metabolic unit, and I got sent a patient, a very unusual patient, by the most senior, most experienced gastroenterologist in Houston, because she had ulcerative colitis and some other problems. And I remember in those days, the only diagnostic technique they had was sigmoidoscopy. And long story short, when I followed down the details about where the diagnosis was made and what it was based upon, it had been made by a psychiatrist. And there was no data of any kind that supported it by histopathology or anything else. So a psychiatrist made a diagnosis of ulcerative colitis, and she was being treated by the most senior gastroenterologist in Houston for that disease. In fact, what she had was intestinal lymphangiectasia. So I started a book then, and it was called Gullible's Travels. And I think most of you guys are set up for a chapter. So
I'll write the introduction for you.
So don't believe, I never believe anything. I go with the St. Thomas rule. I put my hand in the wound before I believe it. And in this case, there's no evidence that she ever had ulcerative colitis. And so I just throw that one out. And so as soon as you throw that out, you're left with this funny histopathology that we know very little about, and an old lady. And so you say, I want to see you every year. Thank you very much.
Thank you, Dr. Graham. That's the game plan that we have, at least until now. But I think I wanted to see what Roy will share with us so that we can figure out a little more.
Well,
But at least-
one more quote from Herb Fred. Herb Fred's one of his famous quotes and actually published was, "What is the best way to cure cancer?" And the answer was, change the diagnosis.
Yep.
Thank you, Dr. Graham.
Thank you, Dr. Graham. We'll let them know at MD Anderson. Appreciate it.
We have a very limited amount of time here, but I would like Ravi to show the only endoscopic documentation that is nicely done to show the connection between SEC and colon cancer, multiple colon cancers. This is like a serious stuff. The other part that you should have done is that, as Dr. Graham said, you needed to document the disease again. So you should have done multi-segment biopsies to document disease activities and chronic changes. So let's look at this series of pictures that I've been like begging the Singapore group to publish, but they are like not very fast with writing.
We will certainly write this soon. Can you see the slides now?
Yeah.
Yes, yes, very nice.
So the story, the context is she's a 70-year-old lady with a very long history of pancolonic UC. So she came for surveillance, and the surveillance done 2 years ago was normal. And then the second surveillance, one of my colleagues performed, and he found something, a small nodule. And then he wanted me to have a look. So that's how this patient was sent to me. She was otherwise well, her disease was well controlled. She was on very low dose of immunosuppressants. So this was her cecum. The bowel prep was very good. And then we started to perform chromoendoscopy. Her ileum was looking normal. The other segments of the colon was all looking normal. This was also normal. We can see the nice innominate grooves. And once we reached the sigmoid colon, something which struck us was compared to the adjacent mucosa. One second. Yeah, compared to the adjacent mucosa, we could see that there is a little bit of granularity in this portion, which is not as smooth as the surrounding bowel wall. So then we looked around if we find similar looking areas, but we couldn't find anything. Then we wanted to focus more on that particular area. Here we again we can see how do I annotate? We can see that there is a granular looking structure or a mucosal abnormality in the center. The border is not very clearly visible here. We can see that it has a border, but it's not very well defined. In which case, we wanted to look at it in a little bit more detail. So we try to use concentrated indigo carmine. So this is like the appearance of that lesion in different looks. Then we sprayed indigo carmine, which is slightly concentrated than what we use for chromoendoscopy. Now the lesion becomes suddenly very clear. We can see that it's like finger-like projections. It has a clear border. There is no innominate grooves that is running through this lesion. We can compare to the sides. I can't kind of like annotate it, but we can see in the sides, you see these parallel lines, but within the lesion, it's like as if we are under the sea, like you can see the sea corals like projecting there. So then we suction the fluid, it becomes even more beautiful that this lesion is huge, extensive, and then there is no innominate grooves running through this lesion. So this is the entire extent. And then we suction and wash that. And then out of curiosity, we just wanted to see how does this lesion look like if we do an NBI? And we did the NBI, it looks not brown. Conventionally, when we, although NICE is not like applied in a setting where you have IBD, but if we were to like compare the same thing with NICE guidelines, this doesn't look brown to begin with. Anything that looks brown is like an adenomatous lesion. Here we don't see the lesion to appear brown. So this is the entire lesion, like the picture which you shared initially, the area which was appearing green in the rectum. We see similar kind of appearance in this patient as well in narrowband imaging. So then we slightly moved distally, like 4 or 5 centimeters away from the lesion, and we found this irregularity. This was what my colleague was referring it to as a nodule. But here we can see that this is not just a simple nodule. This is elevated. It doesn't really have a smooth surface. And there is erythema and EC friability. Then we look closer. What was interesting is there's two things that we need to take a look at. One is the lesion by itself, which is like protruding towards the bowel lumen. And then if you look at the periphery of the lesion, we see the same structure, which is what we saw just now using chromendoscopy. We see the same sea anemone-like structures, or we see the same coral-like structures at the periphery. So this
You're
looks,
talking about 6:30, 7 o'clock, right? At the bottom,
yes,
right?
I'm
Okay.
talking about 6:30, 7 o'clock. I don't know, I can't annotate it. I want to annotate, but
Yeah, so
Yeah.
basically what Ravi is saying is that there is the reddish area, and then if you look further away from the scope, focusing at about 6 to 7 o'clock, there is a continuation of the lesion, but it's not red. That area is what he's talking about.
yeah, right. So then we biopsied both the lesions.
So Ravi, maybe you stop right there.
Yeah.
What does the panelists think this lesion is all about?
So this lesion is not what I saw for sure. And this lesion is probably going to show you some adenomatous component.
Okay, Selvi.
You know, we're talking about serrated epithelial changes, so I would think that that's
So the difference between this image and your image is that the Ravi is doing the second stage of chromoendoscopy, which is the darker evaluation of a lesion. So first stage is that you do it to find areas that look reddish or that looks elevated or depressed, and you are finding the non-polypoid lesions. Lesions could be serrated changes, serrated sessile lesion. It could be neoplasm. And the second stage, once you find an area of concern, is to increase your concentration of the chromo and really look at the lesion in much more greater detail. This is among the most beautiful images that I can think of this lesion, because now he shows a continuation of a bumpy area between 6 to 9 o'clock now, and then but then that area looks not really expanded, and then between 6 to 3 o'clock there is a lesion that's probably is in the submucosa. This is until I can prove it that it is not. I think this is like maybe more than a T1 cancer in the setting of serrated lesions. There is a reason why the area between 6:30 to 3 o'clock is looking elevated like that. And the reason is something is filling up the submucosa. So it's either, and there are very few things that fill up the submucosa. It's a neoplasm, lymphoma, or neoplastic of the epithelium, or desmoplastic reactions. I would be very concerned about this area.
So let me ask Ravi, you showed several images. The first set of images where you showed a very subtle lesion, that's not what this one is.
So there is an area of like between this lesion and the bumpy lesion, which I just showed. There was a column of normal looking mucosa of at least 3 to 4 centimeters between this well circumscribed lesion and the bumpy lesion here.
Right. So these are two separate lesions you're showing.
Exactly. So
Okay.
there were 2 separate lesions that I'm showing.
What was
And,
the pathology of the first lesion?
So coming to the diagnosis, endoscopic diagnosis was cancer.
No, first lesion.
Okay. Okay, let me go to the pathology. So this is the biopsy we took from this lesion. And here, what we can see is we can see the serrations in the, how do I annotate? 1 second.
It's okay. Just describe it. Tell us. Talk to
So
us.
here, just hang on. Let me just.
You should
So
be
we-
able to annotate through Zoom.
Yes.
Oh, okay.
So we can see this area, which
Mhm.
which is like a crypt, which is dilated, which is L-shaped.
Mhm.
And in the subsequent slides, which is even more clear, we can see a lot of serrations down here.
Mhm.
Surgical specimen.
So show us the cancer.
It's here.
Yes.
And then when we go to the next slide, which is the biopsy of the second lesion, you could see the cancer here now.
Mhm. Mhm.
So,
So the first lesion that you saw was not cancer.
so the first lesion which we saw was not a cancer. The first lesion which we saw was a serrated epithelial change.
Right.
And
So
the
we're
second
not
lesion,
dealing with that change going into cancer, right? There's another area that was cancer.
Mhm.
yeah,
Right.
But
there
the
was
both
another.
areas have serrated changes. The second one has serrated, my understanding. Serrated one has serrated changes and carcinoma.
Mm.
Exactly.
It's contiguous.
So let's go back to the image again. So this was the serrated epithelial change, where
You
we
guys
can,
took a biopsy from that, right?
yeah, so we took biopsies from this, and the histology corresponding to that is here. We can see all the serrations down here, the L-shaped crypts, and then at a closer
But
look, you can see this.
what
The
you're
second
showing is
thing-
a resected specimen,
Yeah.
right?
So the second thing is this one, where we also see similar changes at the periphery here, and we also see this bumpy lesion. And the biopsy or the resected specimen actually shows cancer, T1 cancer, which is going down. And this is the resected specimen. In the resected specimen, we can see this is normal appearing mucosa, and then we see the serrations here. This whole thing is like the serrated epithelial change.
And where is
And,
the cancer?
and in a longer view, we can see the serrated epithelial change here, and this is the cancer. This is the cancer, which is going deeper. And this is the normal looking intervening mucosa. And at the periphery of this cancer, we can see similar changes,
Okay.
the serrated epithelial change. So this looks like two pieces because when they cut open the colon, they cut through the cancer. But this is one half of that bumpy area, and this is the other half of the bumpy area. And you see the serrated epithelial change at the periphery.
Yeah, beautifully done.
Wonderful.
And I think the biggest.
So you guys believe now that there is this I sent you in the chat some papers on this entity. Go ahead, Ravi. Sorry to interrupt.
Yeah, so I actually shared a couple of papers in the chat also. I think I'm sure Roy also shared a similar thing. The bulk of evidence actually comes from Johns Hopkins by this Alisa Parian, who has published extensively on serrated epithelial change. Basically, in histology, what we are looking for is the crypts. The crypt exactly, the serration is it follows like a serrated polyp. It's like you see all this in the top and the bottom, you see boot-like structures, but it does not reach the muscularis mucosa. And then we see a lot of goblet-rich cells, so which is typical for serrated epithelial change. And the question is, in terms of cancer, whether it will be KRAS or BRAF. I think from the studies that has been published, they have a combination of both, and it doesn't really follow the pattern like how an SSA transformed to cancer. So yeah.
Thank you so much, Ravi.
Question. So how should we regard the sessile serrated epithelial changes? Are there an entity within the sessile serrated lesions, or is this a separate entity?
What do you mean with that?
We have sessile serrated adenomas or polyps with and without dysplasia.
So yeah, this thing is like
Specification.
the scientists are. We are trying to describe this. We are not like 10, 20 years down the line. I'm sorry.
Yes, I understand. Yes. So that's
We
it's a very
don't have the evidence that you love to have. The
Okay.
evidence that you love to have can only begin when people recognize and open their mind that there is new entity, that diseases are still being described up until today.
Absolutely. I fully agree. Thank
Yeah,
you.
but nobody has
I
any
have a quick
problem with
comment.
that. But there's no problem with that. But the problem is that then to take it to the next step and say, I found 5 cells like this and you're going to get cancer and I need to do something about it, is a tremendous leap forward from having a real lesion that says that this came from somewhere, but we really know nothing about the natural history.
I'm in agreement with you, Dr. Graham. I think what you have said, if I correctly understand it, is that, look, you need to establish the diagnosis again. You need to biopsy it according to every segment, assess the disease activities, and you need to like really evaluate the extent of disease, image it very well, and then you need to biopsy the different areas, because the dysplasia in sessile serrated, the one that's very obvious, like what Ravi just showed, is obvious. The one that has the real adenoma changes is obvious. But there is a segment of it whereby the dysplasia hasn't been described and is not really known what they look like endoscopically. We have been looking at our own experience, whereby I just like casually cut a sessile serrated, and then I was like so surprised that the pathologist said, "Oh, there's dysplasia there," and I said, "Says who?" So I went and looked at the pathology, and they are correct that there are adenomatous changes that are completely flat, and endoscopically we are not yet able to discern them. So what Raji was trying to say, well, I'm going to like biopsy this area that looks dilated and all of that. I agree with you, Dr. Graham, that is nonsense, because we actually don't know yet how to find the dysplasia in the sessile serrated changes. We unfortunately we are so limited, so we need to do random biopsies, and then if your pathologist said that, oh, it's the hyperplastic, we all gang up against you and call this hyperplastic. There is no way on earth that you can say, I'm now going to cut it using ESD. What is the basis of you to cut it using ESD? So then you need to have the people who can say, no, MD Anderson Group, this in our IBD center is called sessile serrated changes. They probably will say, we do not know yet how to follow these. You may need to, in these elderly patients, you may need to do a close follow-up with a sigmoidoscopy every year or whatever, but it is just not known.
So let me ask you this question. One thing is you say that okay, one of the problems that we have with this lady is about the diagnosis. You go in and the random biopsies that the referring guy did, we're going to get those slides. Actually, we're getting those slides. The report was normal looking. So I go back and take biopsies and the entire colon looks normal with no changes, nothing to suggest remote IBD.
meeting lo unnanu.
Does it make a difference?
It doesn't, because the knowledge of SEC has not permeated down through the chain for people in the community to can be diagnosing this. I look at this literature and I talk to some of these pathologists. I know of only like 4 people in the world who have talked about this. One is dead. So we need to talk to them. We need to ask them. I mean, what do you guys think based on your collected experience?
Can I
What
make a
about
quick
this
comment?
association with IBD though?
How-
It sounds like,
Are
how
they
is
real? Are they real IBDs? I mean, they're all patients with active disease or proven disease. Or remember, we're very poor about making the diagnosis of Crohn's or ulcerative colitis. The pathologists have a very limited number of diagnoses, and they frequently make wrong ones. In fact, in the last 4 years, I've seen 4 cases of TB being followed for Crohn's disease, and actually one patient with a toothpick perforation that was about to start on Remicade. So, I mean, the answer is, what's the evidence or the data about the IBD and how severe IBD, and is it healed IBD, or is it another disease that we just missed?
I don't know. Let's ask Ravi. Did you come across this? All I know is that this disease has not been described in non-IBD patients.
But the question is, again, were they really IBD patients? It's like my patient was not an IBD patient.
Well, as far as we know, they come up from people that are in the IBD center. So we have
But
to
I mean, they know what they're doing, because all the patients I just described came from an IBD center patient.
Yeah, but
I mean, you don't trust anybody, right?
Don't
Not
trust
even
anybody.
yourself. That's
Right.
why you do all these things.
It is possible.
That's why I think you need to come. I would write to the pathologist at no offense to the pathologist at MD Anderson, but I would write to the Johns Hopkins pathologist. There's a very prominent IBD pathologist there. She probably will be so thrilled to see these.
Okay, send me the name.
Okay.
All right. So
That's
say,
a
for
great
example, let me
case.
ask you this question, okay? Given the fact that we don't know a lot about it, and given the fact that this is a 70-plus-year-old, would you put her through a circumferential ESD? I'm not planning to put her through a circumferential ESD of 7 centimeters that will cause her a big change in her quality of life, as well as not knowing whether we are going to do her a favor. So what do you answer for that question?
I think you're missing 2 things. You're missing what Dr. Graham said. You need to establish the diagnosis of IBD. So you need to go back in and biopsies all of the parts.
Okay.
Biopsy proper.
Say, for example, if the diagnosis of IBD is established, then what would you do?
Okay. Then I given of her age, I would like do the concentrated dye spray that that Ravi talked about. We talk about, and then do random sampling. And establish that number 1, this is SEC, and number 2, that there is no dysplasia. So there are like 3 things that you must do.
Okay, if it is SEC with no dysplasia, what would you do?
Then the answer is not known, and it probably will depend on the patient's preference. As far as I know, if there is no dysplasia, changes of sessile serrated don't go into the rapid phase of neoplastic. So then you probably can say, well, maybe we just follow you according to the protocol and just follow it every year. But then some people go crazy. Oh, no, there's something inside me that may become cancer. They say, we
No,
want it out. We want it out. So then the best option for that would be an ESD.
Okay, that sounds good. I want to thank everybody for their input. This is one of the best conferences that we have had. And personally, I want to thank you all for helping me manage this patient because this was bothering me. That's the reason why I brought this patient. We discussed this at our PATH conference last week. And then I'm glad that I brought this one. And I want to thank Roy. I didn't share this case with him. I didn't share this case with anybody. I
wonderful.
really appreciate you all for sharing your input. And this is one of the best conferences I had personally. Thank you.
Thank you so
Thank
much.
you.
Dr.
Thanks,
Graham.
everyone.
Thank you, sir.
Thank
Thank
you.
you so much.
Happy Memorial Day.
Happy Memorial Day.